I'm completely confident that that will all be in your mind, so make this particular lecture actually quite easy for you. So as the title says, pharmacodynamics, drug interaction and toxicology. So just to remind you, clinical pharmacology, if you didn't already know, is the study of effects of drugs and their mechanism of action on the bodies of the patients that you prescribe them to. So pharmacokinetics, you will remember dearly, is the effects on the drug by the body, so what the body does with those compounds that you prescribe and put into these people. The effects on the body by the drug, that is its therapeutic effect. Is it going to lower blood pressure? Is it going to kill bacteria? What's it going to do? And then there's the effect on drugs by other drugs, and that's what we're going to really concentrate quite a bit on in this lecture. Right, so the overview, which is really a revision for you because you know all of this. I could ask you to give this back to me. But we'll talk a little bit, remind you, I should say, about the key concepts in pharmacodynamics, and then we'll look at drug interactions, drug-disease interactions, and then ADRs, adverse drug reactions. And most of the session will be on these latter three points. Now, in terms of the key concepts in pharmacodynamics, and important in toxicology as well, is drug concentration and the response. How much drug you give, what dose you give, and what it's going to do. And that is governed then by the affinity of that drug for whatever target it's going for, the efficacy of that drug, how good it is at producing that response, and its potency in terms of the therapeutic effect compared to, say, other drugs. This chap, Paracelsus, some people think he was the father of toxicology. Dosis sola facit venenum. That simply just means that the dose dictates the poison, if you like. So all drugs are poisons. It's just a matter of how much you give can result in a toxic effect. And here's an article from a Birmingham newspaper where a man drank 6 pints of water over a 20-minute period, and that was enough to kill him. So something as benign as water, but if you give the dose high enough, you can get some quite dramatic effects, such as death. Okay, so we get into the revision now. So how do they work? So really, when you inject a drug or give a drug orally, and it's an antipsychotic drug, for example, or a renal drug, how does it actually get to where it needs to go to? Drugs can act by a variety of ways. They can depress systems or they can stimulate systems. So this would be blocking systems or activating systems. They can destroy interactions or they can be replacements, so mimics. Any drug that mimics. So insulin is a good example of a replacement drug. Now, most drugs, as I told you 12 months ago, work by interacting with endogenous proteins, whether they're receptors or enzymes. So those that activate those endogenous proteins are agonists, you'll remember. Some that antagonize those or inhibit those enzymes or proteins are antagonists. And there are a number of drugs that don't fit into that neat classification. I'll just mention a couple of those in a minute. So one thing I only thought of doing about 5 minutes before coming in here is actually have this as a blank slide and sending you an email and asking you to send me what you thought or where you thought drugs worked. And I'm sure that you would get I'd receive an identical list to this. So cell surface receptors, we spoke about those in receptor pharmacology. Beta receptors, for example. There are nuclear hormone receptors. Steroid receptors are example of those. Enzymes or ion channels for a lot of heart pills work on those, transporters, and then signal transduction proteins. So lots of different proteins that drugs can interact with. But there are a number of drugs that have rather unconventional mechanisms of action, probably quite crude mechanisms of action, if you like. So you can disrupt structural proteins. So a series of drugs, ancient drugs actually, called the Vinca alkaloids, they degrade the cell cytoskeleton, and then it causes those cells to break down, and they're used in cancer and colchicine as well, similar kind of thing for the treatment of gout. These drugs are also very useful experimentally if you're a biochemist and you want to study certain pathways and things. So they're quite interesting from that. Some drugs are actually enzymes themselves. So streptokinase, if you've got a blood clot, it's one of the first things that you'll get to try and dissolve that clot. So you can give enzymes themselves. You can covalently link, so cyclophosphamide is an anti-cancer drug. It binds to guanine residues or bases in DNA, and it causes the cancer cells to stop replicating. I mean, they're actually quite toxic because it doesn't just select cancerous DNA, but cancer cells, because they generate so rapidly, are more prone to drugs like this. And just chemical reactions, so antacids, your milk of magnesia, sodium bicarbonate you take if you've got a bit of acid stomach, and it's just a neutralizing reaction. And then binding free molecules of atoms. So you can use drugs for heavy metal poisoning. So they're chelating agents. So if you ingest heavy metals, you can take these types of drugs, and they bind up the heavy metals and then precipitate them, so you can push them out. So there are, quite an interesting variety of drugs, probably quite rarely prescribed, but apart from these, which you can get over the counter anyway. But don't always just think that receptor pharmacology and enzymology are the only places where drugs act. So we'll have a look at these. I will remind you again of these: agonists and antagonists, partial agonism, and then whether they're competitive or non-competitive. So if you're doing an experiment and you are increasing the concentration of your drug and measuring its effect, you get this a so-called rectangular hyperbole, and this is a Michaelis-Menten relationship, so you see exactly the same thing in enzymology. And from these you can determine what the maximum effect or maximum response of that drug is, and from that you can take a half dose, and you remember that's a measure of the affinity of that agent for that particular receptor or enzyme. Now, to be able to determine these sorts of measurements much more accurately, we can transform this using a log scale. So this is a sigmoidal curve, much beloved by pharmacologists, but you can see you can much more accurately determine things like your affinity and your maximal response. So this is again just a revision from last year's lecture, where we went into this in quite a bit more detail. So if we're looking at an agonist, so the agonist comes down, sits into its site in the receptor, and then you'll get is there a ghost in here? So then, whether you're doing binding or response, then you can measure that, and then you can look at that. So 100% then would be a full agonist. Some agonists don't do that, so this one might possibly have a similar affinity for the receptor, but you can see there's a difference in the size of the response. So this would be a partial agonist. So I can see it all flooding back to you now. Competitive antagonists. So this is where the antagonistic drug, so we've got an example here, naloxone, and it's the one I used last year. It binds in the same binding site to the agonist, so it competes for that binding site. So it's competing for this space here. So you've got the agonist there without the antagonist in, there's your response, and when you put the antagonist in, you can start seeing a decrease in response. Actually, this is binding, so the antagonist is actually binding there, and you can see the reduction in response there. And you can construct some lovely curves here, and you can put your antagonist in there, but you can see as you increase the dose of agonist, you can overcome this inhibition, so you can compete off the antagonist, so you can still reach the maximum effect. So as you put more and more antagonist in, you're sort of shifting the curve in that direction, but you're not depressing that maximum effect. You are able to have your agonist in there to knock the antagonist out. And again, one of the things to remember is when you get an interaction with the receptor, this little square box just doesn't sit there and stay there. It's constantly on it, coming on and off. And while it's off, then the antagonist can come in, and when the antagonist comes off, the agonist can come back in. So there's a dynamic equilibrium there. So here are non-competitive antagonists. This is a little bit different. They still inhibit the response, so you still get a binding, response, and you get a binding effect, and you get a reduction in the response. Now these antagonists don't bind in this box here, they'll bind here, and it'll cause some conformational change in that receptor. So when the non-competitive antagonist comes in there, twists the helical structure of the receptor, and then that reduces its affinity then for the antagonist, or it will reduce its ability to activate the receptor down here in terms of the second messenger signaling. And again, here's an example of a non-competitive antagonist, which is ketamine, which acts at the NMDA glutamate receptor. And the difference between this and competitive is that no matter how much more agonist you put in there, you can't override the depression of the response. So if you see a curve like this, it'll immediately say to you that this is a non-competitive antagonist. It's not binding in the same pocket as the agonist, and therefore the agonist can't displace it and compete it away. And then we come here to specificity and selectivity. Now, all the side effects that you'll see in drugs in your careers going forward, it's probably singularly this sort of thing that's the result of that. Now, some side effects you have to tolerate because the nature of the disease might be so critical, but other sorts of drugs, particularly if you're on chronic therapies, it really, you need the most selective drugs you can get. So this is a Leicester slide, so don't blame me for Arnie here. But actually an ideal drug, and this is one thought actually, an ideal drug should interact at only one site and not any other site, so it's highly specific for what you want it to do. There's a Swedish Nobel Prize winning pharmacologist who actually doesn't believe this. He thinks an ideal drug actually should be slightly dirtier than that, because quite often the way that the biology has developed, if you just antagonize one receptor purely, quite often you don't see any effect in the body at all because we have enough compensation. But anyway, that's just a sideline there. But ideally, the drugs should be so specific it only does what you want it to do. But in the real world, drugs do act at more than one binding site, so there is a collateral effect there. And most often that collateral effect is a side effect. But we shouldn't always think this in terms of the way that drugs are being developed now. They're looking at these other effects as other beneficial effects. So the people are actually trying to design in so-called collateral effects, but those collateral effects that will be advantageous to that particular patient. So I think this would make common sense really. So the more selective a drug is for its target, the less chance that it'll interact with other targets, and hopefully will have fewer side effects. I guess most crucially, anti-cancer agents need to be highly selective because they kill cells. A lot of them are cytotoxic. So the problem with that kind of chemotherapy is, of course, it kills other cells, other rapidly dividing cells, such as your hair follicle cells in your hair follicles and your stomach lining cells. But there are other interesting things. So penicillin is actually a very safe drug. It's highly selective because it binds to a transpeptidase enzyme that's only found in bacterial cell walls, which is responsible for the synthesis of those bacterial cell walls. So it binds and inhibits that. In this case, penicillin acts like a mimic for that enzyme's natural substrate, but of course it sticks to it and blocks it. Bacteria can't generate their cell walls and become more susceptible to the body's defense mechanisms. But mammalian cells don't have a cell wall, so if the target's not there, it's not going to work on it. So, as I said, penicillin is relatively safe. There are some idiosyncratic effects of penicillin, so when you go to the doctors, he will ask if you're allergic to penicillin if you're going to go on it, and that is one of the major problems with it for a few people. We'll talk a little bit about that later. So you can target against specific receptor types, so drugs now. Who remembers the salbutamol and salmeterol story that I told you last year? Because I'm going to get 3 of you to stand up and tell it back to the class. Let me come and pick somebody. I wasn't really. But if we were giving a talk on anxiety, I'd now be able to say what anxiety felt like. So if you remember, salbutamol you can use it as an inhaler for asthma, so it acts on beta-2 receptors to cause bronchodilation. But it also has quite a high affinity for beta-1 receptors, so there's a danger for heart effects. Now, if you remember, it's highly efficacious on here, but not so efficacious on the heart. So the reasons you can get away with using salbutamol in an inhaler is the difference in its effect. Now, salmeterol is a highly selective, it's thousands of fold selective over beta-2 over beta-1, so very safe for the beta-2 receptors. The problem comes, if you remember, if you have a really acute asthmatic attack where you have to go into hospital, they have to introduce the drug intravenously. Salmeterol is not soluble drug. It's insoluble, so you can't infuse that intravenously, or you'll end up killing your patient. So we have to use salbutamol, so you have to be very careful then how that is done, because when you're infusing that intravenously, you are going to see effects on the heart. So the more specific, as I've said before, a drug acts, there should be less actions on other organs, and actually the beta-2 story is actually quite a good one. So we'll look at affinity, efficacy, and potency, if you remember those. So not going to be much maths again, it's a reminder here. So we have a mass action effect, so the receptor is there, the drug comes along, and then there's a binding of the drug with the receptor, and there's a sort of an on rate and an off rate for that interaction, so it can go in either direction. And when it's weighted in that direction, we see the effect that we want. And of course, there are constants that work in those two directions. So in order to determine the affinity, the long shot is, if you remember that curve, I should have put a little one there. If you take that maximum effect and the effect that you've got, then you can divide one by the other, and that will give you a measure of the affinity, or how much that drug likes that particular receptor. So many drugs have got different affinities for exactly the same receptor. So imagine this is an agonist of some sort, and it's on. We're looking at the same receptor. They're all full agonists by the look of when we look at this curve. But as you can see, this one here has a much lower affinity than this one here for the same effect. So if you imagine a much lower dose here, so in order to get the same effect, this drug there's a much higher affinity. So this drug wants to bind to that receptor, and that receptor wants it. A little bit more reluctant here, but you can push the dose up but still get the same maximum effect. So that's the affinity, how much a particular drug likes its receptor or its enzyme. So a little bit of more revision here. So the efficacy is, as you know, is the ability of that drug to produce its response, providing those receptors are being occupied and activated in some way. And then it also describes the maximum effect of that drug, so its maximum beneficial effect. Now, the potency is not the maximum effect, it's a dose required to produce what you want. So if you want to lower blood pressure by a certain amount or lower glucose by a certain amount, you'll fix your dose for that. And then if you compare one drug with another to cause, say, a 5 millimolar reduction in blood glucose, different drugs will do that at different doses, and that's potency. So we've got here one in terms of a perception of pain here, and so if you look at aspirin here, you can see it's way over to the right here. So it's the least potent drug, it's quite a high dose there, but also it hasn't got the same maximum effect. But then if we look at drugs like codeine, a little bit better, and then morphine, and then hydromorphine or heroin actually is much it's much more potent. So you can see then the idea of potency there. Really, one of the things that, you know, as you go on from here is that the therapeutic index is a particularly important measure for you to have in mind, and the whole idea about that index. And what it is the dose, if you like, that causes the adverse effect, whether it's, I don't know, sweating or or nausea or something over the desired effect, which could be whether it's blood pressure lowering or an anti-cancer effect. So you divide one by the other to give a therapeutic index. So it gives you an idea of how safe, if you like, your drug is going to be and how much flexibility of dosing you're going to have for that drug. So if you look at this one, these are two drugs in development now. So we've calculated the toxic dose of this drug and its effective dose. So the first drug we made, this is our desired effect, and this is the adverse effect. We weren't satisfied that that was a big enough window, the difference between those two doses there, because at these doses you're beginning to start to see some toxicity, some toxic effects. So you go away, you fix that, you design some drugs, and the 13 people in this audience that will be expert drug designers at the end of this term, they will design a drug that will look much more like this, so we'll have a much wider shift. So there's much more scope to play with your doses there in terms of trying to get your desired effect for that compound. This is diazepam. So it has three major effects. So its adverse effect is respiratory depression. Not great, because you can die of that. And this is its anti-anxiety effect, and that's what the drug is prescribed for. But it has another effect here, that it's a sedative effect. Now with diazepam, people tend to take them in the evening, so we can tolerate sedation as a side effect in that respect. But it needs this wide safety margin in terms of respiratory depression, because a lot of people with anxiety, they may well have suicidal tendencies, and if you're giving them a drug with a narrow therapeutic index, you're actually giving them the means to kill themselves if they so wish. So you need to make sure that things that cause these sorts of effect have a very wide, and these are thousands of folds different actually. So and with those particular drugs, they limit the number of tablets they put in the pot, so you've got to go back to your doctor quite regularly for those. You can't take them all at once. Oops, that was bit frisky there. So the therapeutic window, that difference between the effect that you want and the effect that you don't want, is a therapeutic window, and that's the space that you've got to play with when you're trying to treat somebody with drugs. So it is the range of doses that you can use. So it has the lowest dose for the positive effect, but as I'll tell you later, giving drugs that has an effect at its lowest possible dose isn't always a good thing to do either. But you need to make sure if you can take the dose up before you start seeing any negative effects that then start outweighing the positive effects. So you do need to sort of monitor that. So drug interactions. Now, this is serious stuff. It's a recent article that, and I'll remind you of this later in terms of the importance of this. It's quite a common reason for people going to A&E departments. And the other thing that's really pressing about that is 3/4 of those are unavoidable. So, and that is the responsibility of the prescribers. So this is a little advert to say pay attention to these principles that we start talking about now. So drug-drug interactions, common, and there are two types. So we've got pharmacodynamic drug interactions, and this is where two different drugs have got two interacting effects. They're not acting in the same place, and they're not directly interfering with each other, but they've got two different pharmacologies that come together. So you could think of this will come up again later, codeine and alcohol. They both have depressing effects in the CNS, but they do it in different places, but the net result is an even bigger depressing effect in the CNS. I'm not going to talk much about this in this particular session, but at the end of the slide deck that you've got, there's a few extra slides in there that talk a little bit about the pharmacodynamic drug interactions. We've got pharmacokinetic. No, I cut and pasted this. I didn't realise we were going to get these flashy effects, so I do apologise about that. The one we're going to talk about are the pharmacokinetic drug interactions, and you will remember absolutely the absorption, distribution, metabolism and excretion, the ADME from last year, and we're going to remind you a little bit about that. And this is what you have to think of all the time now when you're going to start prescribing, is to give due thought to those 4 particular principles there in the way that drugs might affect one another and affect the patient in some way. And as I say, either one of these can have adverse effects. But I was also alluding to that pharmacodynamic drug interactions also can be positive. So diabetics are on metformin. You want to enhance their blood glucose lowering, so you will add on a GLP or a DPP-4 inhibitor on top of that. So there's 2 different pharmacologies there to give a better effect. So it's not always a bad thing. So you write the prescription, the pharmacist does it, the patient takes it, and of course you've written prescriptions for a lot of things. So all the various places that they can interact. So absorption, do drugs interfere with each other to affect the ability of one drug to affect the absorption of another? The metabolism, does one drug affect the metabolism of another? How the drug distributes around the body, how it gets to where it needs to get to, how does that influence the possibility or the probability of drug-drug interactions? The excretion of those drugs, does one affect the ability of the other to be excreted? And that will of course have an effect. And again, the things touching on the pharmacodynamic interactions there. So ADME, you remember this? So dose, elimination. So really the pharmacokinetics is the study. As a reminder, these are exactly the words I used in the slides last year. These were last February's slides, in fact, which is basically the study of the movement of drugs and their metabolites through the body. And it's that traffic, if you like, when you've got multiple drugs, the potential where you've got problems. Now, this slide's a little old now. I think the number is now 10. So if you're in hospital, you're likely to be on multiple drug taking. Multiple drug taking sounds a bit bad, doesn't it? You'll be prescribed lots of different drugs. I think the average is now 10. So you've got now here a risks analysis on the percentage of risk of a drug interaction based on the number of drugs used. So already we're at a point here where 10% of patients that are on this average are likely to have a drug-drug interaction that might not be very good for that patient. And the hospital you're going to, Milton Keynes, is a 500-bed hospital, so you might think on that basis there could be 50 of those patients that are going to be suffering from this. It's quite a lot, actually. So absorption. So this is the absorption of paracetamol from into the blood from the stomach, an oral dose, and you can see it peaks after a couple of hours and then declines as the drug is cleared. But if paracetamol is given propantholine, now propantholine is a drug that could be given with paracetamol because you can use it to relieve stomach cramps, those sorts of pains. So you might be already on paracetamol, but propantholine slows gastric motility. Now, if you remember, drugs are absorbed from the small intestine. They're not, by and large, absorbed through the stomach linings too. The environment is so acid and the drugs will be so charged that they can't cross membranes, but as soon as it gets out into the small intestine, they can be absorbed. And this drug slows that transit time, so it delays the drug reaching the small intestine, so it delays the absorption of that drug. And that delay in the absorption then results in a lower dose achieved by that. So you can see now paracetamol isn't going to be as effective as it was on its own. And the same thing here, so tetracycline, antibiotic, but it binds with iron. So if you're on iron supplements, it'll bind the tetracycline in the stomach and precipitate it, so it'll just pass straight through. So it'll dramatically reduce. So, you know, there's different ways that you can affect the absorption of drugs, either by slowing transit time, interfering with the drug in some way so it precipitates. And also the absorption across the membranes are other examples of the way these things can be done. So volume of distribution, this is, I remember having a little bit of difficulty describing this to you last year, and the reason is it's actually it's a purely hypothetical measure, but what it does do, it gives you an idea of where the drug is distributed, and with that you'll be able to use it as a guide, if you like, in terms of how you calculate the dose of a particular drug. So for example here, you've got drugs with low volume of distribution, such as these. I'm not asking you to remember all of these. Now, if you've got a low distribution, particularly below these sorts of these kind of levels, that generally tells you that those drugs are pretty much contained within the bloodstream. They're not getting out of the blood. So that's where they are. Whereas these, volume of distribution over 200 litres. Now, that's a huge number, and much more than our blood volume, which is only 5 litres. So that's why it's an artificial one. But you need to get your head around the fact that all this is telling you that these drugs are likely to be distributed out into the tissues, and most likely the biggest tissues. So most likely your adipose tissue or other very lipid-containing tissues. So if you take a drug like haloperidol, for example, an antipsychotic drug, it has this volume of distribution because it's in a big bag of fat, your brain, and that's where it concentrates. And all the rest are in between. Now, just as a show of hands, where do you think you're more likely to see a drug-drug interaction, where you've got a high volume or a low? So who thinks you get more of an effect with a low volume of distribution? Who do you think the probability of having a drug-drug interaction with a low volume of distribution? Just right. So who thinks it will be with a high volume of distribution? Right, one person got the answer right. It's the low, because if that drug is concentrated in the bloodstream and you've put another drug, and that's also concentrated in the drug stream, they're more likely to start interfering with each other. You've got high volumes of distribution, so they're kind of out of the way to a certain extent, and it does affect the way these drugs act. So if we were developing this in our SSC here, we would avoid drugs with these sorts of volumes of distribution, actually, because it's telling us that they're not, unless it is a brain drug, it's telling us it's not really going where we want them to go. And if we were going to be developing an antibiotic, for example, we'd probably be wanting the drugs down here because we want all the tissues being perfused. So onto metabolism now. You'll remember the two phases of metabolism. Phase 1, which are the chemical modification of the drugs, usually oxidation, and that's brought about by the CYP450, the cytochrome P450 family, and as I explained to you last year, there's about 70-odd subfamilies or genes within that family. As I said, most of them are oxidases, and they're present largely in the liver, but in other tissues as well, lung, kidney, so that's where metabolism and also potential for interaction can occur. And then there's the phase 2 metabolism, which is the conjugation, only occurs in the liver. The idea for that is to increase the solubility of the modified compound so it can be excreted in the kidney. And if you remember, the more soluble a drug is, the more likely it is, or more easily it is to be excreted. As I said, there's a large family of CYPs. The state is slightly out of date now because it's about 55% of known drugs now are metabolized by the CYP3A4. This is about 25%, the 2D6, and this is about 20% as well, the 2C9. But I'm sure you've remembered all of these. And this one is particularly tricky because it's quite prone to point mutations. So in terms of its activity. So in Caucasians, for example, 7% of the population have quite a dysfunctional CYP3A4. And given that more than half the drugs you like to prescribe are metabolized by that particular enzyme, you're going to cause problems with those patients. And that's particularly true. I think there's a higher incidence of that particular mutation in the Asian communities, particularly Japanese and Chinese Asians. And then, of course, there's the other ones that have importance. as I say, a lot of them, but it's probably these three that are accountable for most of drug metabolism. So if you've got a drug that causes 450 inhibition, then the drug interaction is likely to be relatively quick in its onset, over several hours to days, depending on what the half-life of the drugs are, and also the plasma concentration at that time of interaction. So that's important. So if you inhibit that enzyme, the drug interaction is going to manifest itself quite soon. So here we've got an example here. Patient is on warfarin. And the figure shows now the concentration of warfarin in the plasma on the upper line, and then the clotting time, the prothrombin time, or the INR, if you like, for that patient on warfarin. They're given cimetidine, histamine H2 antagonist, used as an antacid, and you can see straight away then the concentration of warfarin in the blood increases, and so this is over a period of hours. And a consequence of that, of course, is that the clotting time then increases. So in a way, you're enhancing then the effect of warfarin and increasing the risk for bleeds there by doing that. And as soon as the cimetidine stops, P450 activates again, and then the concentration of warfarin comes back down, the clotting time comes back down. And warfarin actually is quite a commonly used drug, but it's also one of the most interacting drugs, or one of the most easily interacting drugs. So if you ever have a patient that's on warfarin, the alarm bell should automatically be ringing. There's also enzyme induction. I told you last year that alcohol is a good inducer of liver enzymes. But it takes longer for that to happen. So those effects take longer then to manifest themselves. So carbamazepine and warfarin, again, both metabolized by CYP3A4. Carbamazepine induces CYP3A4. Carbamazepine is Tegretol, so it's used for neuropathic pain. And this particular example is closer to my heart because my 91-year-old mother is on warfarin, but she suffers from trigeminal neuralgia. And the first time that she went in and was presented with that, they put her on this. And they completely reduced the effectiveness of the warfarin there, and her INR went right down. So now she has to have some other treatment for that. So there's a list of drugs that are inducing and inhibitors, and if you're the sort of person that likes to memorize things, little mnemonic there, so PC-BRAS for the inducers, so phenytoin, carbamazepine, barbiturates, these various drugs, chronic alcohol, and then inhibitors, OD devices, omeprazole, quite commonly given drugs, cimetidine, acute ethanol. Okay, I'm not really asking you to memorize those. It's not just drugs that interact with drugs. I remember talking to you about grapefruit juice. It inhibits several P450 enzymes, particularly 3A4. It has a group of chemicals called furanocoumarins that inhibit these enzymes, and it reduces the clearance of many of these drugs, which is a problem. So if you're on simvastatin, a statin, and you're a patient that's prone to rhabdomyolysis, which is one of the more severe side effects of statins, that's a kind of a muscle destructing syndrome, then if you're prone to that and you're on simvastatin and you like your grapefruit juice in the morning, you're going to end up with a lot more muscle pain than you expect. And that's because you've effectively increased the dose of simvastatin in your blood by inhibiting its ability to be broken down. And amiodarone, same sort of thing. This is an agent that can lengthen your QT interval, and that could predispose you to arrhythmias, ventricular arrhythmias, which are definitely not a good thing to have. And grapefruit juice can lead to big increases in drug exposure. And I think I said to you last year that I think a glass of 250 ml glass of grapefruit juice can probably inhibit your CYP3A4 by 50%. So it's quite potent inhibitor. Another one, which is sort of equally problematical as cranberry juice. It's actually used as a kind of an alternative treatment for urinary tract treatment, and it does have an antibacterial effect in that it stops the bugs from sticking to the urothelium, so it gets flushed out. But it inhibits this isoenzyme form, and that then causes problems with warfarin and increases your risk of hemorrhage there. So this is the advice you give to people on warfarin that you will be giving. Because I dare say by the time you're in a position to be prescribing drugs, warfarin will still be on the pharmacopoeia and you'll still be prescribing it. Like metformin, I mean that's on the pharmacopoeia for the last 60 years, and I imagine it will be for the next. So, right, change of tack now. Let's have some real life stuff. So some case histories that we can talk about here that will really illustrate all the little snippets that I've been telling you about now. So we have here a guy that was weaving all over the M1, driving north. He was stopped by the police. He was breathalyzed, failed the breathalyzer test. They tested his blood alcohol, and it was 95 milligrams per deciliter. And the limit is 80 milligrams per deciliter. He was also taking cocodamol tablets, and he claims that a drug interaction was responsible for his raised blood alcohol. So, who thinks that might be a reasonable, if we've been talking about drug-drug interactions, who thinks that might be a reasonable argument for this? Who thinks that the cocodamol might, I know you know the answer on the next slide, but who thinks that it was, you know, on the face of it, does it sound like a reasonable argument based on what you've heard so far? Silence. So I guess that means you don't. So who thinks it's an unreasonable argument? So you're going to tell me why? Sorry?
Was it because codeine had a high drug distribution?
No, but it's not a million miles away. Codeine slows gastric emptying. Right, so this, remember this, what I showed, so it's the same sort of thing. So actually, he's argued himself into trouble because by slowing gastric emptying, it should have lowered his blood alcohol concentration. So it just proves that you know, he was wrong. So he was convicted. There's one small merit in his argument, and I mentioned this earlier, is that codeine does interact with alcohol by increasing the CNS effects of alcohol by having a depressing effect, but in different ways. There's another one, quite interesting one. Again, a case from Birmingham. Mum was waiting at a bus stop and she dropped her baby. The baby was seen in A&E, but because she was said that she had this blackout, that they decided that they would have a look at her as well. She was on drug treatments for hay fever and thrush, so she was on erythromycin and fluconazole, but otherwise she was well. So they did an ECG on her, and at first squint, nothing particularly exciting until they start going down into the detail. And what they found was that her QT interval was longer than it should be, and drugs that prolong QT interval can cause an episode called torsades, which is ventricular arrhythmia, and that probably explains her blackout. And the problem was fluconazole is a drug that can increase QTc, so it caused a depolarizing or repolarizing deficit in her heart. She had this torsades episode, blood wasn't being circulated, and down she went and dropped the child. Number of drugs that prolong QT interval. Ironically, antiarrhythmic drugs themselves and they're the most likely ones to cause these sorts of effects. But there are a number of non-antiarrhythmic drugs that do have this. So we see also we've got 2 drugs here, which this lady was on, both the erythromycin and the antifungal agent, which is related, fluconazole is related to these drugs. But there are others that can do that. So it's going to cause problems. So there's something else for you now to think about when you're prescribing drugs to patients. There are drug-disease interactions, of course. They're more common at the extremes of age. The older you are, things don't work so well. I know that personally. So the liver's not working so well, the kidney's not working so well, hard to get up in the morning. But things generally slow down a bit. So the way that elderly people deal or handle drugs also slows down with age as well. So age is a risk factor for these sorts of interactions, not only because they're likely to be on multiple drugs, but the whole system is slowing down anyway. And also chronic medical conditions, not surprisingly, have effects on this. So if we look at renal disease, so if you've got reduced renal function, then renally excreted drugs are going to be affected by this. So, for example, digoxin, heart pill, minor glycoside antibiotics like gentamicin, those are things that are going to be impaired. Their excretion is going to be impaired with people with renal disease. And the problem with digoxin, it's actually got a very narrow therapeutic window, so you don't need that much accumulation then to tip it over beyond your adverse effect response. So that's, you know, quite nasty. If your electrolyte balance is disturbed, or drugs that affect that, it might predispose to toxicity, particularly potassium. So if you've got drugs that lower your plasma potassium, hypokalemic agents, other drugs such as your salbutamol inhaler are much more likely to cause arrhythmias if you've got low plasma potassium. And then nephrotoxin again will cause further kidney damage. And actually ibuprofen, over-the-counter drug for headaches and whatever, is a nephrotoxic drug. So if you've got any kind of kidney disease, you shouldn't be putting patients on things like ibuprofen, or shouldn't be advising them to take those. Hepatic disease. So again, obviously, if you've got particularly unhealthy liver, then your P450 activity is going to be completely thrown off course. Drugs are going to then have much longer half-lives in the system, and then you're going to see toxicity. And again, opiates are used to relieve the pain in cirrhosis, because you get pancreatitis there as well. And then, of course, they'll accumulate, and opiates are not good drugs to accumulate, so then you could end up precipitating a coma without you trying to help the person's pain, but inadvertently end up putting them into a coma because of liver disease. So obvious again, so 2 very important organs in the metabolism and excretion of drugs, and kidney as well, not only the excretion of drugs but also to a large extent metabolism of drugs. And then cardiac disease. So if you reduce cardiac output, you're going to reduce tissue perfusion. You'll be reducing the perfusion of the liver and the kidneys, those organs that you're depending on to get rid of drugs. So, you know, if you overdose on your antihypertensive agent, then it's going to reduce the perfusion. They're not going to work so well. So then you'll get reduced hepatic blood flow and clearance. So the drugs are not getting introduced to all the enzymes in the liver, and then the renal blood flow, glomerular filtration will be reduced, so you're not pushing those drugs through. They're staying in the circulation. So, adverse drug reaction, ADR, loads and loads of literature on this, and the official definition of this is that it's an unwanted or harmful reaction that occurs after administration of a drug or drugs and is suspected to be due to that drug. So you've got to be, you know, fairly certain that that's it. And then that's classified then as an adverse drug reaction. They are classified, this is an old classification now, it started in the 1960s after They started taking this quite seriously after the thalidomide disaster, and originally it was just type A and type B, so these are sort of augmentation effects. And you have examples here, so hypoglycemia to overdosing to insulin. And then bizarre effects, so penicillin anaphylaxis. As I said, it's a very safe drug, but it falls into this category of bizarre effects because it's quite rare, but often quite fatal. And more lately, other effects have started to, or other classifications, so chronic effects, delayed effects, end of treatment effects, and then there's F, which is a failure of treatment. You can give drugs and they just don't work, so then you put another one on top of it. But there's a lot of overlapping effects here, so it's not a straightforward classification. So more recently, Jess Arison, somebody we worked with when I was in GSK about 25 years ago, clinical pharmacologist, probably one of the most widely published ones, but he had a particular interest in this and studying this and wanted to have a new approach. So I have this paper actually, if anybody's interested, just let me know and I'll point them in that direction. So I think because of the copyright rules I can't just send out the PDF. So there's a few things that you need in his classifications. Of course, we need a drug, and then you need a patient, and then we've got to put them both together. And then or the article states, so what other features then do you need to look at I'm not overrunning, am I? No. So again, you need to think of the dose and the concentration that determines its effect. So remember the therapeutic window. Then the susceptibility of that patient. Are they old? Are they on multiple drugs? Have they got renal disease, hepatic disease? All those kind of things. And then the time course of that reaction. So then you get a more unifying classification of adverse drug reactions. Now, where do the risks from ADI come from? Well, the top risk, and it outperforms all the other risks, are doctors themselves. And this is not accidental of phraseology here in terms of ignorant, inappropriate or reckless prescribing. I mentioned that 7% of A&E emergencies are due to adverse drug reactions. That then has a knock-on effect in a hospital for taking up 4 beds out of every 100, so 20 beds in a hospital the size of Milton Keynes as a consequence of this, costing nearly £400 million a year. Now, the other shocking thing about that is a recent article looking at all of these emergency risks. Is over 70% of them, nearly 3/4 of them, could have been avoided. So it was due to ignorant, inappropriate or reckless prescribing. So you have to take great care in what you're doing. It's easy to write things down. I think I've said this before. It's easy to write these things down on a prescription pad in your office, but in the real world, somebody is on other things. But other things we've mentioned, polypharmacy, so multiple drugs, and you're likely to be on that, particularly for some, if you've got high blood pressure or metabolic diseases, you are going to be on multiple drugs. Then elderly patients, if you've got multiple medical problems, if you've got all of this as well as a renal disease. And then drugs with narrow therapeutic indices, so digoxin, for example. So you already you should see alarm bells there. And also drugs that are used at their minimally effective concentration, so they're just inside, but if you've got a drug-drug interaction that reduces the effectiveness of that drug, then you'll actually render the drug useless. There are severity classifications for drug-drug or adverse drug reactions, I should say. So major, so these have caused permanent damage to your patient, or you've killed them, and then a moderate, which means that you've got to act in some way to correct the adverse drug reaction. And then mild, which is trivial or unnoticeable, and these are often only found because you're on a trial, the patient is on a trial, and you've measured ALT or AST enzyme elevation from the liver, but the patient themselves doesn't actually feel anything, but you've got an indication that something has gone on. That's a mild response. So what do we do about it? So as doctors, actually, you will have a duty to try and reduce the effects of adverse drug reactions. And as a result of the thalidomide tragedy again, the yellow card scheme was introduced, so you have to report your adverse drug reactions. Now the ones that you do report are those that are severe, so if you've killed someone, hospitalized someone, or caused some life-changing event on that patient, you have to report it through the yellow card system. Other things that you have to report are if you see an adverse event of any type in children, or you see an adverse event of type in the use of vaccines, so they're all reportable. If you look in your BNF, if you've got one, and you see new drugs that have just newly come onto the market, some of them will have a little black triangle beside the name of the drug. That means you've got to report all effects, whether they're mild, moderate, or serious, because they're under increased surveillance by the MRHA, which is the UK's drug and healthcare device regulatory agency. So yeah, there is a duty to do that. So really, just to summarize, last slide now, pharmacodynamics is what the drug does to the body, and you know all about that. And then the drug interactions. So you've got to keep the ADME processes in mind. You've had a revision on that now, so you're all experts again. And you have to appreciate that these things can happen at any time, and you need to be able to react to that. Diseases, particularly hepatic, renal and heart diseases, are going to increase those chances, so then be wary of patients that you look at with any histories there. And then adverse reactions, as doctors you will need to report them and to try and improve this. And thank you for your time. So, any questions before? Oh. You don't have to ask your questions now, but if you think of them later, come and see me or email me them. Okay, thank you. Oh, did you push that for me?
I did at the start.
Oh, thank you. I forgot to do.